My talk is on mitral valve, ABCs of screening and procedural steps. I have no disclosures. So as we heard from Dr. Chandrasekhar that I think all these valvular heart disease will increase with aging population and high risk for repeat cardiac surgery for degenerative mitral bioprocesses and failed annuloplasty rings can actually be increasing mortality and morbidity. So the transcatheter treatment has become standard for aortic stenosis, and that actually has extended into mitral valve replacement, whether it's valve-in-valve or in the future, Dr. Juan Granada will be talking about native mitral valve replacement. This has become a less invasive alternative. So as we see that first actually we should recommend surgery, as Dr. Chandrasekhar mentioned about all these patients, but bioprosthetic mitral valve structural deterioration is about 30% at 10 years, and so this is a surgical literature showing that explant due to structural valve degeneration is increasing with age. What is it due to? Whether it is wear and tear, calcification, pannus, and endocarditis or thrombus on these valves leaflets as well. So there are several bioprosthetic surgical valves. I'll skip these two slides, but recognizing them on fluoroscopy is very important as you know how to identify these valves and how to treat them. So coming to accessing during mitral valve-in-valve, initially I think jugular vein was attempted, and then actually we started with transapical back in 2011, and now it's almost done at transeptal, and some people have done even direct left atrial approach as well. So transvenous transeptal technique has become a common standard now in most patients, and we'll go over that in the future. How you crimp the valve is very important, because transapical and transeptal you need to make sure that the skirt is on the atrial side, and so I think that's very important to make sure that you're crimping on the right side. So this is in 2011, 59-year-old woman with the shortness of breath, repeated admissions for similar complaints, mitral valve replacement in 1982 for rheumatic heart disease with the bioprosthetic valve, and redo in 1995 for endocarditis with the 27 Carpentier-Edwards mitral valve by actually a very profound robotic surgeon, Rani Chitwood, at our institution at East Carolina University at that time. So this patient had actually, looking at this image, it really severe mitral stenosis and mitral regurgitation, and the mitral regurgitation is due to a perforated leaflet, as you can see here. So there's a pinhole that is causing that severe MR. So this patient, obviously, because we are not going to get her off the table and off-label in hospital, Sapien XT was implanted with a transapical approach, and this is the final result after that. And patient who had a cardiac output of 1 liter went to 5.2 liters, and from class 4 to class 1, and she could be discharged actually from the hospital. So, but this was in maybe I think 2019 as a live case in Chennai for CHIP CTO meeting we did actually. So this was transeptal, and as you can see, along with the mitral valve-in-valve, we also closed the paravalvular leak at the same time using the edgeless sheath, and this is done within a short period of time. So coming to screening, what is the most important is actually echocardiogram, whether transcatheter, transthoracic or the TEE is mandated in most of these patients to evaluate, and 3D TEE will help us to identify what is the reason, as we talked about, whether it is vegetations, and I think even though some people have attempted to do in endocarditis, I would strongly recommend not to do a valve-in-valve in patients with endocarditis, because that is going to get again infected because the nidus is in the valve, and we have to remove that valve. Hemodynamic evaluations by both echo, here mean gradient is 9 and 11 millimeters, and by cath actually mean gradient is around 15 millimeters mercury. So this actually is very important to correlate both the hemodynamics in the screening process as well between echo and cardiac catheterization. Right heart catheterization is indicated, and looking at the right ventricular function is also very important in these patients, because even though we think that mitral valve is a problem, these patients might actually be admitted to our institution a day or 2 days early to tune them up with the diuretics or low dose dobutamine to improve the right ventricular function. And if PA systolic pressure is more than 70 millimeters on right heart cath, that's actually a poor predictor for outcomes in these patients. So that has been shown. And if they are oxygen dependent, those patients are also don't do so well with the mitral valve-in-valve procedures. Cardiac CT is mandated. I mean, recently, actually, one of my colleagues posted a valve-in-valve without a cardiac CT. So we nixed it as in our multidisciplinary conference. We said, no, you need to get a cardiac CT first, and the cardiac CT is actually very important because it actually shows how these patients are going to be tolerating the mitral valve-in-valve procedures, because neo-LVOT with the new virtual valve that you can see how much actually is the LVOT reduced to will impact on their outcomes as well. So we'll go over that in a couple minutes later. The sizing with the valve-in-valve has become very simple from thanks to Vinny Bapat, but again in the mitral trial, based on sizing, only 57% were in agreement with the app, and 43% actually either smaller or a larger size. And so I think it is better to do a CT to actually exactly know and understand what is the size of the annulus and what is the size of the valve that you want to place, and what actually happens if you place a virtual valve to the neo-LVOT, and anything less than 250 square centimeters millimeters is not recommended to do, in my opinion, a valve-in-valve procedure. So that said, let's look at in the next 2 minutes a procedural steps case setup. At our center, we use anesthesia, echocardiographer, and interventionalist or cardiac surgeon. Sometimes the echocardiographer is a cardiac anesthesiologist, and so it's mostly done under general anesthesia. We are still trying to do with a 3D ICE. We don't have much of experience except 1 or 2 patients. I'll show it to you. But in general, TEE is what we recommend, and a single vascular access radial artery is obtained by the anesthesiologist. We just place one access to the femoral vein and a single proglide, and if that fails, actually a mattress suture can be placed later. So the first step is actually transeptal puncture, appropriate location. For the valve-in-valve or mitral balloon valvoplasty, similar to that, you should be mid to mid in position, and not really posterior as it would be for transcatheter edge-to-edge repair. This is from my previous partner, Al-Kholi. He has actually nicely demonstrated in a JACC intervention article that where should be the puncture in the fossa. So mitral clip or a TEER procedure will be more posterior, whereas the transcatheter mitral valve replacement is mostly like a mid to mid in the septum. So this is how you can do in case if you want to spend a little bit more money, using a VersaCross wire, and actually it is a radio frequency wire that can puncture the septum very easily. I actually still the SL1 and BRK needle as actually because it is a little bit cheaper. And so once you cross, you can use the same pigtail catheter that is actually with the VersaCross wire, and then you can cross it and make sure that the height is good, and then advance the dilator and the sheath. So the height of the puncture should be between 3.5 to 4 centimeters, and because if it's too high, then actually you're going to be struggling a little bit more. So then the next step is septal dilation. You can use anywhere from, I use large balloons, so usually about 12 or 14. Some people use 10 millimeters as in this case, but actually typically 10 to 12 millimeters septal dilation is required. And the same balloon is passed into the mitral valve to do just a flossing in the mitral valve position to see how the device will behave when you push this device, whether the pigtail will come out. So crossing, actually, before I go there, crossing into the mitral annulus, I usually use the edgeless catheter and a mitral multi-purpose catheter through the edgeless sheath, and place a small glide wire through that, and then exchange the multi-purpose with the Safari or extra stiff Amplats or Lunderquist wire, whichever wire you want to use. The more stiffer it is, the more chances that it will be kicked out. So if you can actually get into it, it's difficult. Then the anterior rotation of the catheter will help you to get towards the mitral valve, and then you can actually use an omni-flush catheter and then slowly replace it. Sometimes you might have to actually put a transapical puncture and snare that wire to create a rail. So that's another important part that we might have to do in rare occasions. So here is a patient with the mitral valve and degenerated mitral leaflet, severe MR, and this is done under ICE catheter. As you can see with the 3D ICE transeptal crossing, we just start using this in the Philips system. And once you cross, ICE catheter is placed in the left atrium, so we can see very well. And we do this now actually for standard of care for all of our left atrial appendage closures amongst 3 out of 4 people. So then you cross the valve, as we said, and inflate it, and you can actually, with the ICE, you can see that it actually is working quite well. The mean gradients have come down in this patient from 11.5 And one word about neo-LVOT, this is what we are talking about. These patients have a higher chance of LVOT obstruction, and probably preemptive alcohol septal ablation will help in such patients. So this is how the septal thickness has been reduced with alcohol septal ablation, and we have done in some of the patients as well. So in conclusion, the transcatheter mitral valve-in-valve interventions are a great option for high-risk symptomatic mitral stenosis or mitral regurgitation. LVOT obstruction can be predicted by CT, which is indicated, and alcohol septal ablation or lampoon may be required in some patients to prevent LVOT obstruction. With that, I'll stop here. I'll be happy to take it.